My name is Randall Packard. I'm professor of history of medicine here at Johns Hopkins University, director of the Institute for the History of Medicine. We teach courses for graduate students, medical students, students in public health, undergraduates, on a range of topics. My own work is on social history of disease. I work on the history of health and disease in Africa and the history of international and global health. My first interest in malaria came when I was in the Peace Corps in the late 1960s, and I unfortunately came down with malaria. I was not alone in that many of the people amongst whom I was working also got malaria. I was fortunate that I was effectively treated and got well. Many of those around me did not. I was working in a clinic. Young children in particular would come, and some would survive and some would not. And I became interested in malaria and other diseases. I was involved in a trachoma eradication project, or trachoma being an eye disease project. And so at the time, I didn't think it as a serious topic to be studied, but I was interested in it. I went on, got my degree in history, and eventually came back and became interested in the history of disease, and malaria kept coming back, and I kept coming back and writing about it. So I've been writing about the history of malaria since about the 1980s, early 1980s, in various ways, and most recently completed a book in which I sort of pulled together many of the things I've been thinking about malaria, and I've learned about malaria over those years. Yeah, well, malaria is one of the oldest diseases that we know that's affected humankind. Probably had its origins in sub-Saharan Africa, Southeast Asia, and that would be 100,000 years ago or more. It really becomes a serious problem probably about 10 to 6,000 years BC in sub-Saharan Africa, and eventually spreads out from there into other parts of the globe. One of the most important things to know about malaria is it's not necessarily a tropical disease. That is, it has had historically much wider distribution than it currently has. And if you look even at the end of the 19th century, there were cases of malaria that were occurring in Canada, they were occurring in wide areas of Europe. In 1922-23, there was an epidemic, major epidemic of malaria in Archangel, which is a city some 200 kilometers south of the Arctic Circle. What all these places have in common, however, is that you have a situation in which you have a convergence of a mosquito that can transmit the disease, the parasite that causes the disease, and a human population that's susceptible to the disease. And those things come together at particular points in time, and they often come together because of larger forces that are shaping society. So malaria is clearly a disease that is shaped by broader patterns of social and economic development. And you can see that in early Rome in the 4th century, where malaria becomes a very serious problem in the areas around Rome, and it's associated with economic and social disruptions associated with warfare and the abandonment of land. And you can see it as well in the other areas in which it spreads into Europe. Malaria probably enters into the Americas sometime in perhaps the 15th century. And as best we can tell, it comes from Western Europe and arrives primarily from early European settlers. Many of the English-speaking settlers who settled in the colonial America came from areas of England that were infected by vivax malaria. And so you have episodes and descriptions of malaria in the lowlands of South Carolina, Maryland, Virginia, as well as stretching up further north from the 16th century forward. Sometime at the end of the 16th, beginning of the 17th century, you begin to get the introduction of falciparum malaria, which is the more deadly form of the disease. And that, as far as we can tell, arrives on the board of slave ships and with Africans who were brought over from Africa to work on plantations in the Caribbean, Latin America, United States, what becomes the United States. And from those coastal areas where it emerges, it spreads inland, along with settlers moving into the interior. And by, as I said, the end of the 19th century, malaria occurs from the farthest northern areas of the United States down to the Gulf Coast. It occurs from one Atlantic to the Pacific in various places. And it's only over the course of the next 100 years that it begins to recede. And as we've seen, it recedes not necessarily because there were any particular successful ways of controlling the disease, but that the disease, as I said, was associated with certain patterns of development, and that as those patterns disappeared, as there were improvements in agriculture, improvements in housing, the introduction of cattle, all these things contributed to demise or decrease in the extent to which malaria occurred. And in the United States, it becomes largely a disease of the southern United States by the beginning of the 20th century. And it remains part of the disease in the middle of the 20th century until after World War II. But DDT was relatively cheap. It could be spread over large areas. It lasted for long periods of time before you had to respray. And so DDT and pesticides became the major instrument for fighting malaria by the end of World War II. The successes that were achieved by using DDT, and in some places actually eradicating the disease, led a number of malaria specialists and public health authorities to believe that it was in fact possible that you could use DDT to eliminate the disease globally. And it was this confidence in DDT, plus the fear that DDT might be lost as a weapon as mosquitoes develop resistance to it, that led the World Health Assembly in 1955 to vote for the program for the global malaria eradication of malaria, the global eradication of malaria. And that program ran from 55 up until 1969. It had major successes, but particularly in more temperate areas of the world. Malaria was eliminated from southern Europe, where it still existed, in the southern United States. It was eradicated in a large number of countries that fell into one of three categories. Either they were relatively well off economically, they were island nations, which made it relatively easy to eradicate the disease, or they were socialist governments in Europe, and the fact of them being socialist was less to do with their economic policies than the fact that many of these countries had well-developed primary health care systems. And this contributed to their success in controlling malaria. There were lots of other places where malaria was brought down dramatically, and certainly mortality was brought down dramatically, including India, large areas of Southeast Asia. Eradication wasn't really attempted in sub-Saharan Africa except for in South Africa, and there were successes in South Africa. In most of those places, however, eradication wasn't achieved. Efforts to achieve eradication dragged on, and for a number of reasons didn't achieve their goals. And by '69, the World Health Organization decided it was time to evaluate what had been achieved. And what they decided was that in the areas where malaria had not been eradicated, it didn't look like it was going to be eradicated in the near future, and that, in fact, they should step back from eradication and implement control programs with the hope that eventually they'd be able to eradicate. And that led to a great deal of disillusionment amongst those who had supported eradication, and also a sharp decline in funding for malaria control activities worldwide. And that decline in funding lasted from roughly the early 70s up through the early 90s. And over the course of that time, malaria actually makes a major resurgence in many of the countries in which it had been brought under relative control, though not eradicated.